Welcome to Cardiac MRI Simplified at mricardiac.com. This is Dr. Bhavin Jankaria, and today is my day, the first Thursday of the month. And my case, and this is the 182nd case that Priya and I have put up, Priya having done three-fourths of them, and it's titled Double or Triple Trouble. So this 58-year-old patient was referred for workup. She had one episode of failure 3 years ago, and echo showed multiple findings then and now. And you can see on the short axis 4-chamber and 2-chamber that there is dilatation of the LV. There's mitral regurgitation, but the RV is normal. So if the T1, T2 stir, late GAD, all normal. This is just the septal artery in case you're wondering if there's mid-septal enhancement. So if you summarize the findings, there's reduced LV function with normal RV function, moderate diffuse hypokinesia of all the LV segments, mild to moderate mitral regurgitation, and normal multiparametric images. Now, last week or last month, I talked about fish mouth and hockey stick and how, as MR radiologists in India, we must know how to diagnose rheumatic mitral valve involvement. And I had these two signs, hockey stick and fish mouth appearance on the short axis. Now, when we look at this case again carefully, you find that the anterior mitral valve leaflet is abnormal and actually does show a hockey stick appearance with a mild fish mouth. You can see that here, that the valve commissures don't reach the surfaces as they normally would. And so there is rheumatic involvement of the mitral valve with MR but no MS. So if you add that in, that's an additional finding. Then if you look at the LVOT views, there's aortic stenosis. We knew that the patient had aortic stenosis from the echo and apparently had a bicuspid valve, which I'm coming to. So we measured with phase contrast imaging. It was 2.4 meters per second with a gradient of 22.7. So that's the bicuspid aortic valve that was visualized on the transaxial. But we need to be able to say what bicuspid aortic valve this is. And if you remember my case 148, there are 3 steps to do so. One is to orient the cine specifically, then check whether it's 3 sinus or 2 sinus, and then subclassify it further. So you have to first orient it, which means that whatever may be the orientation initially of the transaxial view, it should be such that the interatrial septum is at approximately 7 o'clock position. And so we did that to our case, and now this is the interatrial septum at 7 o'clock. And now you can see what it looks like here. Then the second is it 3 sinus or 2 sinus? And between systole and diastole, you would be able to make out, and as in this case, it's a bicuspid aortic valve when it opens up. But when it is closed, and I'm using these terms just so that there's no confusion, you can make out that it's a 3 sinus bicuspid valve, whereas here it's 2 sinus. And in our patient, if you see clearly, there are only 2 sinuses that open up here, and so this is a 2 sinus, not a 3 sinus bicuspid. And then you have to further subtypes. If it's 3 sinus, you figure out whether it's right left fusion or not. But when it's 2 sinus, you need to figure out whether it's lateral or antero-posterior. And clearly this patient has a lateral 2 sinus bicuspid aortic valve, and that's how you'd be able to classify it. And so when you add all of these things together, you can put in here that it's a 2 sinus lateral. The last thing left is the aortopathy. So you would give all the measurements at the annulus, the root, the ascending aorta, etc., which, if the patient is going in for corrective surgery, would be important as well. But the whole idea of this case is that given the burden of rheumatic heart disease in India, it is not uncommon to see patients with subclinical mitral valve disease presenting often for other reasons. Now, most of the times they'd be picked up on echo. This patient wasn't. This patient had subclinical rheumatic mitral valve disease with a bicuspid aortic valve, which was developmental, and a dilated cardiomyopathy. Was the dilated cardiomyopathy related to the AS? Was it related to something else? We're not sure. We're also not sure whether the mitral regurgitation is related to the LV dilatation or is it due to the rheumatic mitral valve disease. So a lot of things to be sorted out, and perhaps they will never get sorted out. So after the MR, the cardiologist went back, repeated the echo, and they confirmed that there was subclinical rheumatic involvement of the mitral valve. And that's the reason for the case. One is obviously to reiterate how to characterize a bicuspid aortic valve. And, it's just nice. In fact, I use my own presentations each time I get a case and just go through the steps so I don't have to memorize them because they are all on my laptop and I can do that. And similarly, now with the mitral valve, I have learned how to pick up subclinical rheumatic mitral valve disease. And I sometimes feel bad. I did my sabbatical in cardiac MR in 2003. Oh, sorry, 2002. And then we put up the MR in 2003. And then it's 21 years later that I'm getting a sense of what rheumatic mitral disease looks like on MR. Nobody taught us. There have been no papers, nothing. I don't know if I'm going to be able to write this up, but otherwise, this is basically how you would pick it up, and it's all up there for everyone to look at. That's my WhatsApp channel. The book that started everything. That's my Atmasvast book. And, thank you so much for listening to me. Take care. Bye-bye.